Good evening, everybody. Welcome to this session of ISTK Pgclinics. This is an extra class. I think from now onwards, we'll be having weekly classes. Next month, the first two classes will be clinics and the second two will be on recent advances. And as exams are nearing, we'll be having frequent classes. And you also have to provide us the case details as early as possible to identify the faculty. So I welcome all the participants and all the other attendees. And the general rule follows. This is a bar round, so we'll be showing the case. You will read through it fast and then arrive at the conclusion. The faculty will ask you rapid fire questions. The questions may be anything on the history, the physical findings on the lab, on the management, anything can be asked. Okay. So with these words, we will start off. So, Dr. Sai is the first person.
Yes. Good evening, sir. Good evening, ma'am. First case is a 44-year-old male presented with the chief complaints of yellowish discoloration of eyes for 5 weeks, abdominal distension for 2 weeks, and altered sensorium for 1 week. Jaundice was progressive in intensity and associated with high colored urine. No pruritus, stool color is normal, no abdominal pain or fever. History of presenting illness, abdominal distension followed by lower extremity swelling and associated with decreased urine output. He also had altered sensorium with altered sleep pattern and irrelevant talk for past 1 week. No history of hematemesis, no history of melena or other bleeding manifestations. No history of preceding prodromal symptoms, CAM intake or NSAID abuse. No history of breathlessness.
This is one of ma'am's earlier cases presented 2 years ago. Continue.
Non-alcohol use disorder, daily consumption of more than 60 grams per day, last consumption up to 2 months ago. History of jaundice 2 years back, for which he has taken CAM and subsided after 3 weeks without hospitalization. No history of previous comorbidities or surgery, no family history of liver disease, diet history, calorie intake of 1800 kilocalories per day and protein of 60 grams per day. Overall deficit of 500 kilocalories and protein deficit of 20 grams. On examination, patient is drowsy, obeying oral commands, GCS of 12/15, heart rate of 78 beats per minute, blood pressure of 110/70 millimeters of mercury. Patient is deeply icteric and had bilateral pedal edema. Abdomen, systemic examination for abdomen, liver, spleen not palpable, distended, shifting dullness plus, CNS, and no visible veins or no tenderness. Central nervous systems, flap could not be assessed as patient is drowsy, and pupils 3 mm reactive to light. Moving all the forelimbs and reflexes, plantar or extensor. Respiratory and cardiovascular systems, normal, no abnormality detected.
Ma'am, please take over. You are muted, ma'am.
So what are the possible causes in this patient? You want to discuss 5 weeks history of jaundice and recent history of decompensation with hepatic encephalopathy.
And he is also having a past history of jaundice 2 years back. So I feel patient is having underlying chronic liver disease, which is decompensated now with a second episode of jaundice and abdominal distension, ascites and encephalopathy.
Okay, is that the only possibility? Is there any other possibility? Suppose that 2 years ago, he had only an acute liver illness and it subsided completely. And this is a totally independent entity, what he has developed now. So if he had liver disease 2 years ago, what do you think is the current problem? What do you call that syndrome?
Current syndrome within period of 5 weeks gap is there, so he would not fall under ACLF. So he would fall.
What is he coming under? What category? We're not asking what he does not fit in. What are
acute decompensation? Acute decompensation
Of what?
Okay.
Acute decompensation of?
underlying chronic liver disease.
So what is it? For more than 4 weeks, 4 to 8 weeks will be what?
Subacute.
He developed altered sensorium at 4 weeks of illness, no?
5 weeks and 1 week. 4
Total
weeks.
duration is 5 weeks, no?
5 weeks.
Okay,
But
1 week.
jaundice.
Okay, so at 4 weeks he developed altered sensorium.
Because the gap between jaundice and encephalopathy is only 4 weeks, so he would fall under acute and chronic liver failure category.
Can it be acute liver failure?
Acute liver failure.
From the onset
it's-
of jaundice till the development of liver failure, what is the duration?
From jaundice to encephalopathy in this patient is 4 weeks, sir.
Okay, therefore it is one is you said, okay, ACLF plus or minus according to duration. Second,
Acute.
can this be ALF?
Yes, sir. It still can be ALF with if the previous episode of jaundice is not a part of this illness, it can still be an
But what
acute
is
liver.
strange here? If you consider it as an ALF. What is the strange?
What is ALF?
How does they manifest usually?
Severe coagulopathy.
Okay,
Jaundice.
coagulopathy is one feature. Another one, clinically.
Ascites will not be the presenting
Here
symptom in
this
acute.
patient had ascites, no, and edema
Yes.
from the beginning. So it doesn't look like ALF, no. Patients usually have jaundice followed by altered sensorium. They on examination or investigation, they may have ascites. Okay. But this patient had pedal edema, ascites, pedal edema much earlier, and altered sensorium came much later, maybe 3 weeks, 4 weeks later. So it doesn't look like ALF, not the classic. So one is ACLF, second is ALF, though unlikely. Third, can it be a simple decompensation of a chronic liver disease?
Yes, a simple acute decompensation of an underlying chronic liver disease.
Can it be anything else?
Give all your differentials, no, for a patient who's got jaundice, sudden onset of jaundice with ascites and edema leg going in. Can it be outflow tract obstruction? Give all the possibilities, no?
Outflow tract.
Sorry?
Hepatic venous outflow tract obstruction might be a possibility because jaundice followed by ascites, but I'm not sure how common is encephalopathy in outflow tract obstruction. So I'm not sure.
What any patient with outflow tract obstruction, if they have end-stage liver disease, they can have encephalopathy. You know? So what are the features that are happening in the history and examination? No, that's what you have to describe.
Are CLD patient more vulnerable to hepatic outflow, venous outflow obstruction?
Yes.
Why?
Because of the regenerative nodules and distorted architecture of the
Okay, because
liver parenchyma, the hepatic veins.
even though we have coagulation abnormalities, it is equally a thrombophilia state, no? There is. Second thing, an HCC can develop and it can also add to the problem.
What are the other possibilities? Could he have developed a portal vein thrombosis? What is resulted in decompensation in this patient?
Maybe the sudden decompensation of in this patient might be one is a part of natural history, or he might have developed an underlying hepatocellular carcinoma, or he might have an.
Can it be a reactivation of viruses? Come on, give us all the possibilities, no?
One is HCC or portal vein thrombosis.
1 minute. What is the current disease state and what are the things that could have precipitated this sudden decompensation is your diagnosis, no?
Yes.
Does he have cirrhosis?
Do you think he has cirrhosis of liver? Okay, it's an intelligent guess. All of us may be wrong or right.
Yes, sir.
Is it possible that he's having cirrhosis with portal hypertension? And what is
Yes,
the jaundice is part of the etiology that is taking place in this patient, and he's got this chronic liver disease, cirrhosis, portal hypertension.
Yeah, ma'am. He's got cirrhosis with portal hypertension, which is manifesting as portal hypertension in the form of ascites.
The form of?
Ascites.
What else? What are the other things that tell you that it could be having an underlying cirrhosis and its complications?
One is history-wise, he is having all the three features of hepatocellular dysfunction, and examination-wise, he is ectopic and has flaps, and he is also having ascites.
So what are the complications he's having? Does he have a renal dysfunction?
He has decreased urine output as well, ma'am, but that might be a part of renal dysfunction, but without the labs, it would be difficult to comment whether he would be having
What
a
is the
renal dysfunction.
mechanism of oliguria, madam? Right? Why does the patient get oliguria?
Renal vasoconstriction, but it can be either pre-renal cause or a renal cause, ma'am.
So we're not asking theory. I'm not asking theory. In this patient, do you think that he's got a renal dysfunction or he does not have renal dysfunction?
He has renal dysfunction.
He has. He might have. Why? What is the definition of oliguria? Why do you have a doubt that there could not be a renal dysfunction? What is the first presentation of a decompensated chronic liver disease? What's the very first presentation? Oliguria is the first presentation. It precedes everything. The urine output is the first thing. He keeps saying that he passes normal urine, but actually it will be an oliguric phenomenon. So oliguria is the first presentation of any patient with chronic liver disease. So if a person says I've reduced urine output, you're not comfortable with that statement, is it? You want a biochemistry to say that he's got AK or HRS. Huh? We're asking you only for a renal dysfunction, no?
Yes.
Agreed or not?
Yes, ma'am. I agree.
So what are the cause of jaundice in this patient now? What are the cause? This patient has got jaundice, no? What are the cause of jaundice in this patient?
Yes. One is function.
Sorry? I can't
Hello.
hear you.
Ma'am, am I audible, ma'am?
Your voice is breaking. Tell me, yeah.
Hepatocellular dysfunction causing jaundice.
What are all the causes, doctor? One is hepatocellular jaundice. You think it is probably due to what? Due to what?
What's the cause of jaundice and cirrhosis, Sai? What's the usual cause of jaundice and cirrhosis? One is diminished hepatocellular reserve. No, there is less liver cell mass. Then, other than that, acute insults on the liver, on the remaining parenchyma, like
acute reactivation of viral hepatitis.
like acute inflammation due to viruses, drugs, toxin, vascular insult, anything. That's the way you should think, and then try to target on most likely etiology. You should have a broader outlook to the problem. Okay, suppose you are seeing the patient at bedside without any history. What would be your diagnosis?
Decompensated liver disease.
He has all features of a decompensated chronic liver disease with what all features?
Decompensated chronic liver disease in the form of jaundice, ascites, and encephalopathy with an underlying renal injury.
Okay, so he has all these features. So whether it is a decompensated chronic liver disease or whether it is an ACLF depends upon the duration, that period, whether there was an acute onset or a short history of jaundice, all those things that we look at. Okay, if you think it is ACLF, what do you think is the cause for the acute precipitation?
One I would think of any underlying activation of viral hepatitis or patient would have
Is there
developed
much more likely cause in this patient?
One is because he has alcohol intake.
Yeah, he continued to use alcohol and his last drink was 2 months ago. So a person who is drinking, he was stopped drinking 2 months ago. Is it possible he can develop an acute insult like alcohol hepatitis now?
Within 2 months, within 60 days of onset of symptoms, if he has alcohol intake, it
Yeah,
would
so that
probably.
the period is correct. So he could be having alcoholic hepatitis on top of a background alcoholic liver disease also. That is it can happen, no? On the remaining liver cells also is affected due to his continued alcoholism. So if the history is there, strong history, and if the primary etiology of cirrhosis and the current acute insult could be same etiology. Or the liver disease could be due to chronic liver disease due to alcohol, and the current etiology could be a different one. In which case, is there anything in the history which would suggest that it could be a different etiology? Is there any risk factor as per the history?
John, he had jaundice and
Yeah, he had a jaundice 2 years
jaundice.
ago. He took some cam and then.
Yeah, ma'am.
Okay. Is there any drug, other drug intake? Is it possible that it is a delay, acute delay, and that is decompensated?
Maybe, sir, because there is no obvious history in the.
There is no obvious history, so we can't say. Okay. Can we proceed, ma'am?
Yeah, I suppose so, yeah. Very hesitant, no, she is very doubtful and you have to be very confident in your presentation. Now, can it be
Yes.
subacute hepatic failure? Everything is falling over to 5 weeks. What is subacute hepatic failure?
Subhepatic hepatic failure, 4 to 12 weeks of duration.
What are the outliers and what is subacute hepatic failure? What
Sorry,
is the
ma'am.
definition of subacute hepatic failure and what are the outliers?
Onset of jaundice to encephalopathy duration of more than 4 weeks or less than 12 weeks. It comes under category of subacute liver failure. I'm
So,
not sure.
that is the definition. Huh? What is the definition? What will be the underlying liver disease?
With a pre-existing chronic liver disease
Pre-existing.
diagnosed.
What's the difference between
Diagnosed.
Is subacute liver failure seen in chronic liver disease or an acute liver disease?
Acute liver disease, sir. Subacute liver failure is seen in acute.
So it's an acute.
Right. So it is a liver failure occurring in a patient who's got an underlying normal liver. The two situations when you the outliers are Wilson disease and alcohol-related hepatitis. Both these are outliers. They will have underlying liver disease, but they will behave like subacute hepatic failure. Read Dr. S.K. Acharya's paper and Dr. B.N. Tandon's paper. And what will be the biopsy in subacute hepatic failure?
Extensive inflammation with no evidence of fibrosis.
Submassive necrosis is the word. Submassive necrosis is a submassive necrosis. And what is the natural history of subacute hepatic failure? Mortality, this versus ACLF or ALF?
Compared to ACLF, mortality would be low and there are high chances of.
Just the reverse. It will be very high mortality. Once a person goes for subacute hepatic failure, they have all these apoptotic cells. It is a natural death of the hepatocytes. The mortality is very high. Even when they do a transplant, they have a poor outcome. So please read about subacute hepatic failure.
I can look at the LFT 1 on 31.3 and then subsequently the last one.
Bilirubin was 43 and conjugated component of 21 on 31st. It has come down to 39 and 26, but it again gradually increased to 41 to 27.
So look at the other parameters and tell us is your diagnosis correct or not?
AST to ALT, AST more than ALT 189 and 56, 148 and 47. Albumin to globulin ratio. Albumin is 2.6. Globulin is also on lower side. Ammonia is very high, 190 and 123. SAP and GGT was also elevated. So hypoalbuminemia and low platelet count, evidence of total hypertension.
Does a patient have an underlying liver disease? What's your comment on the platelet count?
Platelet count 1.8, 1.5 and 1.3 lakhs. Evidence of portal hypertension, suggestive of portal hypertension.
1.8 is low. What's the normal platelet count?
More than 1.5 to 3.
More than 1.5 is patient has got thrombocytopenia. No?
No.
What is the normal platelet count?
1.5 to 3.5 lakhs platelet count.
100,000. So 1.8 you think is normal or reduced?
Normal.
So what's your comment on that? 31.3 to 3.4. It's just about 4 days difference. Do you think the patient has got advanced liver disease or do you think it's a normal liver disease?
No.
It's not anything. It's not that reduced, no? It's not that
That's
reduced.
a minor reduction only. No?
It's only minor reduction. What's your comment on
So the
creatinine?
INR is elevated, albumin is low. What
Low.
about the AST-ALT ratio?
AST to ALT ratio more than 3, sir.
Okay, so what does it mean?
Suggestive of alcohol-induced damage, alcoholic hepatitis.
Okay.
Bilirubin 43 and AST to
Anything in electrolytes?
Sodium is 124, hyponatremia with hyperkalemia 5.8.
Okay, so what all this patient has on admission?
On admission, he had,
Does he have cholestatic features?
ma'am, sorry, ma'am.
Does he have cholestatic features?
Alkaline phosphatase and DGT are elevated. GGT may be a part of alcohol-induced damage. ALP is also elevated. Yes, ma'am.
Does he have cholestatic or not, doctor? He has, no? He has
Yes.
cholestatic features.
Yes, ma'am. He has
What
cholestatic.
are the cause of cholestasis in this particular patient? How do you explain the cholestatic? Raised alphas and gamma GT. There could be underlying sepsis, no? The blood counts.
Blood counts
Counts
are
are,
increased.
PC count is 15,000. So when there's underlying
Maybe-
sepsis, they have what's called as bilirubinostasis. They'll present just like cholestatic jaundice. There'll be rise, huge bilirubin, and they'll also have raised alphas and gamma GT. What are the other possibilities of raised alphas and gamma GT in this patient? Other possibilities that you are likely to miss? HCC.
HCC development as a precipitating event.
You have to comment on that. Okay, so move on. Let's move on. So does he have an AKI or no AKI?
Is creatinine.
I don't know, it's not mentioned here. Okay, I think creatinine,
Sir, it is a 4.1.
yeah. We'll find from other values, whether it is there or not. Okay, you continue.
His CRP is 9, ferritin is 353, slightly elevated. Viral markers, HBsAg, anti-HCV, anti-HBC, IgM are negative. HEV is negative, anti-HAV is also negative. Ascitic fluid count analysis
In this
showed
patient,
high
in this patient, you'll ask for anti-HBC IgM and anti-HAV IgM, HEV IgM. What's your comment?
one is anti-HBC IgM just to rule out reactivation of any
What do you
active
expect the results to be?
enzymes to be very high.
Then why are you asking for those tests? Please be very careful, we just want to know your approach to the patient. So in a patient who has just got a borderline 3 times elevation of AST and ALT, AST more than ALT, in this situation, would you ask for HEV IgM? Will you ask for HAV IgM? Will you ask for anti-HBC IgM? When will you ask for HAV IgM in a given patient? Which patients will you ask for HAV IgM?
Young patient with very high elevated, more than thousands of SGOT and SGBT with prodromal symptoms.
What percentage of adult patients you expect HAV IgM to be positive?
Very less, exact number not sure.
Less is what, 5%, 20%, 30%, 40%?
Not sure of the number.
What is the HIV prevalence in an adult population in the country?
5 to 10%.
5 to 10%. Patient is HIV, adult patient will be HIV positive. So what happens in the pediatric age group versus adult age group HIV?
HIV is usually more common in adolescents and pediatric age group compared to adults.
Adolescent is not same as pediatric. Please read all that. Okay, when will you say the patient has got high SAG and low protein?
High SAG is when the serum albumin to ascitic fluid albumin gradient is less than 1.1.
globulin in this patient? And would you ask for a SAG in this patient? 2.2 by 2.9, 2.2 by 2.3. What was the can you go back? What was the albumin globulin?
Hello.
Only 2.2.
Albumin globulin is 2.4. Albumin is 2.
So you expect, so patient has got low albumin and globulin. What was your comment on that? What is the possibility? What are the possibilities? Both albumin and globulin are low. All these you have to keep in mind, no? In that context, would you consider high SAG in this patient where the albumin is also low, serum is also low, everything is low?
Yes.
So be careful when you're interpreting that, okay?
Okay.
And when do you say there's a low protein? When do you say there's a high protein?
Low protein is less than 2.5 gram and high protein is more than 2.5.
You're very hesitant, okay, when you're answering. You're very, very hesitant. You have to be very confident in when you answer that. What is exudate? What is transudate? That's what we are asking for, okay?
Okay.
And what's the interpretation of the ABG?
pH acidic metabolic acidosis, high lactate levels, metabolic and lactic acidosis.
So it's got metabolic acidosis, okay. And we just move on.
USG abdomen Doppler showed a shrunken liver of 9.4 centimeters and portal vein is dilated with 14 millimeters and he's having splenomegaly with moderate ascites and fused splenorenal.
What is the interpretation? So he's got cirrhosis, he's got portal
cir-
hypertension. Endoscopy also confirms that he's got portal hypertension.
Portal hypertension.
Any other investigations you need? Do you want any further investigations or you're satisfied?
And alpha fetoprotein levels and the serum creatinine.
Serum creatinine, I don't remember often, but I think it was slightly elevated, 1.8 or something like.
Alpha AFP levels.
That was
If
normal.
it's normal. So what's the final diagnosis now?
Decompensated chronic liver disease in the form of SI.
Cirrhosis of liver with portal hypertension. Any doubt on that? Why should you keep using chronic liver disease, chronic liver disease? It is the patient who's got cirrhosis, full-blown cirrhosis with portal hypertension. You agree to that? Collaterals have been described. Hyperammonemia is there. Everything is there. So what type of encephalopathy does he have? A, B, C, D? What type is it?
He's having C type, ma'am.
Why do you say so? Why not cirrhosis? A? It's not A. Bypass. Can it be C? Why are you saying B?
C, ma'am.
Huh?
C, type C.
Yeah, can it be a B?
Only mild splenorenal collaterals are there.
Is there any other possibility in a cirrhotic patient where B type can be there? Suppose the liver function is perfectly okay and the patient is developing repeated encephalopathy.
Large splenorenal shunts.
Any other shunts?
Most common. Which is the most common shunt? Which is the collateral that opens up? Which collateral opens up? What drains into the portal vein?
L.
Can there be any vein which actually obliterates in the infancy and then come up later due to portal hypertension?
Umbilical, obliterated umbilical.
Can that happen?
Yes, sir.
Okay, some people may have a persistence of the umbilical vein. It may not obliterate at all.
In which other condition you can get at birth or 2 years or 3 years?
Abernethy malform.
What is it, doctor? You tell me.
Congenital portovenous shunts.
Portovenous shunts, sir. What is it? What is abernethy? What is patent? What is patent ductus venosus? What is patent ductus venosus? All these you should know. Okay, this is all too basic, real basic questions that we're asking. Do you know what is ductus venosus?
Persistence of the umbilical vein and presence of umbilical to systemic shunt.
Ductus venosus,
Ductus
madam.
venosus. There are two things
We are
which will
not asking
obliterate
of
soon
umbilical.
after, but ductus arteriosus and ductus venosus.
They're asking
Okay.
Venous channel communicating the IVC and the portal.
one communicates. Which one
Okay.
communicates? Devu?
Venous channel communicating
Which
the
venous channel? Which venous channel? No, sir. SM is superior vena cava. Left branch of the portal vein that communicates with the IVC.
IVC.
That's what is seen at birth. If it fails to obliterate, it remains patent and it can present as hyperammonemia. These are all the congenital. They're all congenital. At birth, you have this patent ductus venosus. You can have large umbilical vein which does not obliterate, as Dr. Varghese mentioned. So you must know all these things. So what do you think is supposing I take a hepatic encephalopathy in this patient? Can you just tell, is it overt, covert? Number one, what will be your Glasgow scoring? What will be the type? What will be the cause? And what's the precipitating factor? All these 5 points you have to highlight in your presentation. The 5 columns.
Person is he's having an overt encephalopathy with West Haven classification of class 3, and it is unprecipitated encephalopathy.
It's intermittent or episodic or continuous?
This is the first episodic. So episodic, first episode of an altered syndrome. So episodic encephalopathy.
And then precipitated by?
Precipitated by dyselectrolemia, mostly hyponatremia and then metabolic acidosis.
All this you have to mention when you're talking of the complication. That's when we know that you have some knowledge of all these things. Okay. Okay. We can move on. PT.
Okay. Do you want to ask a question on any of this, ma'am?
Yeah, the management. Then we have to discuss about the management. That this is actually not a
Creatinine
ward
is 4.1. Creatinine is 4.1. Yeah.
Yeah, it will be more of a long case. It will not be a ward round case.
Okay. This is more.
Correct
So we'll stop at this level.
Yeah. So at this stage, can you just tell quickly how you manage each of these problems?
Hyperbilirubinemia, there's no specific management. If any underlying precipitating factor is there, alcohol abstinence or any virus reactivation based on the investigations, nothing is there. Only alcohol abstinence I would do. And dyselectrolemia, hyponatremia, and hyperkalemia. One thing is he has altered sensorium, would not be taking any adequate food intake, so supplement with IV fluids and potassium lowering agents, as well as give him an nasogastric feeds, and renal dysfunction.
How do you correct the low sodium?
First,
What are the causes of this patient?
low sodium one, it can be a decreased food intake, or it can be because of renal dysfunction in patient.
Decreased food intake. How often lesser food intake causes hyponatremia?
First thing would be a renal dysfunction causing hyponatremia because of dilutional.
Why does it cause dilutional? So one is dilutional. Number one. Number two.
Fractional excretion of sodium would be.
They're not asking that. They're just asking you what are the causes of hypovolemia.
The most common cause of hyponatremia in a cirrhotic with ascites speed edema.
Dilutional.
One is dilution. Okay. Second is?
If patient is already on a pre-existing diuretic induced.
Diuretics. Third? Okay, some patient may go for severe salt restriction. Doctors may say some salt restriction, but patient can actually go for severe salt restriction. Added to diuretics can lead to this. Okay.
And what's the comment on the creatinine?
Creatinine is very high, 4.1, with ultrasound showing normal.
What's your comment on that, and what should you do? How do you manage?
Kidney injury.
Acidosis. He's got hyperammonemia. Do you think he needs a nephrologist opinion and a CRRT? What's your comment on that? Which can correct the metabolic acidosis and hyperammonemia. Those are the things that you have to address in this patient. Apart from your regular management of hyperammonemia, patient's got metabolic acidosis that has to be corrected. That with hyperammonemia, CRRT are some of the other options that will help this patient. He doesn't look like as if he's an AKI, no? It looks more like a patient who's got a renal dysfunction and everything is packing up. He's going for a packing of these renal function. He's going in for encephalopathy. So he's a candidate for liver transplant. You have to consider liver transplant in this patient. His MEL will be huge. So you have to calculate that and then to get the ARC score if you think it's an ACLF. All these things you have to discuss, okay? So he's, how old is he?
I think 48 or so.
48. So you think he should be actually listed for liver transplant? Correcting all these, he needs to be listed for liver. He's only 48 years old. And what is your comment on alcoholism and liver transplant in the present days?
Within
Is it a
Last-
contraindication?
6 months abstinence prior
The
to liver
patient does
transplant.
come in a situation of hepatic encephalopathy. He is not even able to answer you. And the patient in the hospital in the ICU. And do you want 6 months abstinence?
No, sir.
Then
In
what
this
will you
patient,
advise?
it is not a contraindication for liver
Okay.
transplant.
So what's the risk of recidivism in these patients? So they have seen, so if the family is coming forward for a liver transplant, you have to push in these patients for liver transplant. Okay, and people have shown that the recidivism rate is not as high as is expected. And even at the end of 2 years, 5 years and all, patients are still, doing well, even though they have had this alcoholism. And there's always a delay in the onset of cirrhosis and its complications in the post-liver transplant, even if they start drinking. Okay, so these are the things that you have to read. You must know about the liver transplant in this patient. They will ask you that question. So these are things. I think any other questions that you would like to comment?
I think we have covered it extensively, though we thought of doing it as a ward rounds. There was a request from the part of the residents that CLD was not discussed, its management was discussed. I think almost everything was discussed, but this also shows that CLD being a very common problem and it will come in the examination and you must be thorough. And you should not have any doubts, no, any hesitation whatsoever when you answer. Because this is the most common IP case in the ward, no? CLD, decompensated. So you must be absolutely thorough, read up, catch up, and present more cases. So thank you, Sai Kiranmai. We will go to the next person. Okay. Who is next?
Sir,
I think Sobin.
yes.
Okay, Sobin.
Sir, my case is a 45-year-old male bank officer, alcohol 3 drinks per day for more than 10 years, no binge. Last drink 4 days prior to admission. He presented with jaundice for 10 days, abdominal distension and edema legs for 5 days. No abdominal discomfort.
Okay.
No present or past history of GA bleed, decompensation, hepatic encephalopathy. Urine output adequate, bowel movements normal, no CAM intake, no comorbidity,
Okay, no
not
problem.
married, vegetarian. On examination, patient is conscious oriented, height is 154 centimeter, weight is 62 kg, corrected BMI.
What is corrected BMI?
Sir, that is based on the dry weight that we have to
Okay.
calculate from his actual weight. If there is mild ascites, 5% should be reduced, moderate 10%, and refractate is 15%, and another 5% should be reduced from bilateral pedal edema.
Look at the right panel.
Okay.
Pallor,
Sir,
right side, pallor present. Okay.
pallor present, bilateral pedal edema present, icterus present, no lymphadenopathy, SpO2 98% at room temperature, no asterixis, malnourished. Vitals.
Okay. So
peripheral-
what are the peripheral signs of alcoholic? What are the peripheral signs of alcoholic related liver disease?
more specific signs of alcohol-related liver disease includes peritonomegaly, then spider angiomas, and
Is it
then
affected only alcohol?
no, it can be seen in other cause of chronic liver disease, even in
Suppose you
pregnant.
see these signs, there is a high probability of underlying alcoholism. What are those signs? Okay, parotid enlargement degree.
Peritonomegaly is
Pardon?
Dupuytren's contracture.
Dupuytren's contracture. How do you assess sarcopenia and malnourishment in this patient?
Sir, sarcopenia, we can assess.
Or what
One
are the
is
tests
getting
of
the
sarcopenia?
Ideally, it is a CT scan or MRI at L3 vertebra.
Is it possible to do it at bedside?
No, sir.
It is
Sarcopenia,
not at all
otherwise you
possible.
can. Okay, sir. We can assess by the mid-dam muscle circumference, mid-dam circumference, and then tricep skin fold thickness.
Skin fold
Uh,
thickness assess sarcopenia. Skin fold thickness assess subcutaneous fat.
Okay, sir.
Triceps, mid-dam circumference, okay, agreed. Triceps skin fold is the area where you do it so that everybody will do it uniformly at one particular place. Okay.
Okay.
There are some studies where people do it intrascapularly or interscapularly, etc. But this is the muscle mass. So mid-arm circumference, one is. What are the other methods we use at bedside to assess sarcopenia or frailty?
Hand grip strength, sir.
Okay,
Yes,
hand grip strength.
Then 6-minute walk test can be done
Okay.
for frailty. Then gait speed.
Okay.
mm,
Is there any objective method? Are there any scoring systems to assess this sarcopenia? Grading or scoring? Okay, we'll show it up later. So CVS respiratory normal, psoriatic plaque seen over the dorsum of hand. So is it relevant or irrelevant?
It is relevant, sir.
Why?
In the setting of because he may be on a methotrexate.
What is
for
the cutoff
psoriasis.
dose above which you think that it could be related? What is that called? What does total dosage, cumulative dose?
Cumulate.
The cumulative dose above which you should be very careful when you give methotrexate.
Okay. I can't recollect, sir.
You have to.
Okay.
Finally, I can't say this. I can't recollect. Okay. Is there anybody who is able to answer? Sai?
Because he is alcoholic, a cumulative dose of 2 gram will be.
Otherwise?
Otherwise, 4 grams.
Okay. If there are risk factors for liver disease, okay. Okay. So this is the finding.
Mild abdominal distension. Torches anterior abdominal veins. Liver and spleen not palpable. Shifting dullness was present. CNS examination. Higher mental functions normal. Mini mental status examination 17/30. Cranial nerves
So
normal.
everything is normal. Okay. Working diagnosis.
Working diagnosis with the history of alcoholism. I will first give the diagnosis as alcoholic hepatitis as number 1.
You
What may
consider
be the-
alcoholic hepatitis. What is staring at you? Those findings.
Those findings are ascites. It may be the first presentation of decompensated chronic liver disease.
What are these things?
They are dilated torches.
So what does that suggest?
That suggests a chronic liver disease.
Portal hypertension.
Portal hypertension.
Collateral. So that means in a situation like this, cirrhosis liver. No, I think you all have tendency to say chronic liver disease. Now that NAFLD is also chronic liver disease, you have to be specific. Okay, cirrhosis liver with the portal hypertension and ascites. That means decompensation.
Decompensation.
Okay.
Okay.
So that should be your diagnosis. So this is the investigation. Look at it. Do you find anything abnormal? I think
Pallor is there. Leukopenia.
prothrombin is prolonged.
Prothrombin
Platelet is WBC is low. Platelet is low. INR is 2.
2. Sir,
Bicytopenia.
pancytopenia, that is
Pancytopenia or bicytopenia, obviously, plus anemia. Then,
anemia.
so what does
Then,
it shows?
It shows a hypersplenism, sir.
So,
In
so when do you
case of
usually get
cirrhosis or-
hypersplenism? Portal hypertension,
portal
splenomegaly.
hypertension, splenomegaly.
Okay, so yes, cirrhosis liver, portal hypertension, decompensation in the form of ascites plus hypersplenism. How will you manage?
Sir, first, he is severely malnourished. So I
Okay,
will
look
first
at this
correct the
LFT
nutrition.
also.
23.
So is there anything other than a routine decompensation or something more? On day 28th May when he presented and 21st June. So what does this show?
That
Delhi.
it It
So the
can be
initial
a
panel
drug.
on 28th May shows what?
I mean, conjugated hyperbilirubinemia means it's very high
Okay.
bilirubin. Now it is came down to 8.4. So probably it may be a drug also may be there. Daily have to suspect in as he's having psoriatic plaques, he may be taking some treatment.
Psoriasis methoxide produce acute hepatitis like picture. Does it produce acute hepatitis or a chronic type of picture?
In
I
the
think you have
chronic
to
type of
read it
picture.
thoroughly. Okay.
Yes, yes.
We will proceed further. And the aim of showing this case was, okay, what does the ultrasound show?
Ultrasound is showing
What-
a
What is,
coarse liver. Coarse,
okay, what is
coarse
this?
liver. So that is ascites.
What about this?
Portal flow is normal.
Okay,
Portal
we are
vein.
not shown the Doppler, so we won't be able to say, okay, cirrhosis liver is a normal portal flow. So what are the various flow patterns in the portal vein and hepatic artery in liver disease?
One is pulsatile flow. Increased pulsatility means it is
Pulsatility of which vessel? Artery is always pulsate, no? The arterial flow is always a pulsation. So,
portal veins.
okay, venous pulsation.
Venous
Venous
pulsation.
pulsation. The two
That
things which
shows
can veins which are closer to the heart, there may be a reflection of the cardiac events on to the veins. On second, there could be an effect of respiration. And
Okay.
third, there could be an inherent pulsation. Okay, these are the three things. So in the portal vein, do you get any pulsation? In the IVC, do you get any pulsation?
In cirrhosis due to the portal hypertension, you can get this pulsation.
Sure. Anyone else who can answer this question? Congestive index, portal vein pulsatility index. Okay, I think nobody is answering. That means you have to read up. The Doppler, Jayanti ma'am, you want to add on?
No. Dino, you should be able to answer Harry at least. What is hepatic artery resistive index? When do you do it? When do you
Resistive
do it?
index.
When is Harry done in a given patient? Post transplant, no?
Post-transplant.
Come on, answer here.
Anybody? Sai's audio is
Post-liver
breaking.
transplant.
Okay, you can
Post-liver
actually have short
transplant.
notes on any of these. See, read up all these things. Dopplers on portal venous vascular systems. Okay, and resistive index. And there have been studies on not only on this resistive index, renal resistive index in cirrhosis liver decompensation. Also, there have been studies the relevance of renal resistive index in a decompensated patient, hepatic artery resistive index, pulsatility, and other things. Okay, so read up all these things and prepare short notes for all these things. Okay, because
So
these
this
are
is for
important things.
patency, the
Normally
Harry
not
is done for
discussed,
the
but
patency of the hepatic artery post liver transplant. So normal is up to 0.84. So when that Harry index is abnormal, then they start suspecting there's hepatic artery thrombosis. What is hepatopetal and what is hepatofugal flow in the portal vein? What is hepatopetal and what is hepatofugal?
normally how does blood flow? Hepatic artery, portal vein, hepatic vein. How is the direction of flow?
What is it
It is
called? What is
reverse.
hepatopetal? What is hepatofugal?
So hepatic artery brings in arterial blood. Portal vein brings in the intestinal blood into the liver. So liver
it's
has two sources.
1 minute. Is it hepatopetal or hepatofugal?
Hepatopetal flow.
You're not confident about that, huh? What is the direction of flow in the blood in the two vessels? Hepatopetal or hepatofugal? That's what we teach. The basics they do not know. That's what I'm saying. No, Javas, See, he's hesitant on this. What is normal flow in the hepatic artery and vein, hepatic artery and portal vein? Hepatopetal or flow? The hepatopetal or fugal?
Hepatopetal. I mean.
Oh my God. Oh my God. Supposing I say it's hepatofugal, what's your comment? I say that the portal vein shows hepatofugal flow. What's your comment?
That
Normal?
is reverse flow from
Abnormal?
no.
Huh?
Abnormal,
In
madam.
which situation you
Related to
get
portal hypertension.
hepatofugal blood flow?
What is abnormal about that? What is
The
abnormal?
flow is reversed, madam.
When will a flow get reversed? So why did you not answer
When
the first question? What is the normal flow to the liver?
hepatopetal flow, ma'am.
So when can you get hepatofugal flow in the portal vein?
That's development of portal hypertension or portal vein
Most
thrombosis.
all portal hypertension, you will get hepatofugal flow.
Portal vein thrombosis, madam.
Portal vein thrombosis, you will get hepatofugal.
In portal cavernoma, how is the flow usually?
What will be the flow in EHPVO? See,
In
please,
EHPVO,
just
what is the direction of blood flow?
yeah,
At least say
please
that.
see, yeah, please see that your basics are right, okay? If your basics are not right, we're not interested in you managing AKI or managing your metabolic acidosis. Last time we had to fail a candidate because just simple question we asked, what's the direction of flow of blood around the umbilicus when the veins are paid? What's the normal flow in this patient? What do you expect? Doctor showed you the veins. What will be the direction of flow in normal and what will be the direction of flow in this patient?
So
Normal.
there are dilated anterior abdominal wall veins. You will look for the direction
What
of
is
flow.
normal?
Okay.
What is normal?
What is
and
normal?
What will happen
What is
in this
abnormal?
patient? In this
From-
patient, what will it be and what is normal?
From above the umbilicus, it is above upwards, and below it is downwards, madam. Normal.
This
So
is
which,
in
so
what?
where
This
do
is
you check?
This is
So
normal.
where do you check usually? Which part of the abdomen you check usually?
Sir, I don't
Which
get.
part of the abdomen you usually check it?
I'm
Check for the
sure.
direction of flow.
Good evening, Shobna.
That is on the anterior
Shobna,
aspect,
this is
over the
basics.
dilated veins.
Okay, or the dilated vein, but there has to be some site on the abdominal wall where you have to do the test, no? So you have the choice of doing it in upper abdomen or lower abdomen, where in a cirrhosis liver with the portal hypertension. The same patient which I showed the photograph. Where will you do? Do it in the upper or lower?
Sir, it's lower.
Why?
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 I say upper, you say lower. Why?
Shobana ma'am
That's
is the
what
umpire now.
I'm telling you the basics.
To
We have
differentiate IVC obstruction and portal.
Okay, normal direction of flow is away from the
Away from the
umbilicus.
umbilicus.
So in a situation where there is a portal hypertension due to cirrhosis of liver, that will be reflected through the umbilical vein or recanalized umbilical vein, the flow will be away from the umbilicus. In a situation where you expect a reversal of flow is when, which is a situation where you expect a reversal of the flow.
When do you get a reversal of
IV.
the flow?
Okay,
IVC
IVC
obstruction.
obstruction. So in an IVC obstruction, what will be the flow like?
Which vessel will change the direction of flow?
The
don't
veins below
understand.
the umbilicus will be from above upwards, from below upwards.
Below upward. So you have to check above in a inferior vena cava obstruction, above the umbilicus, the flow still will be upward. So there's no point in checking the upper portion. So the area where you expect is in the reversal of the flow is in the lower part of the abdomen. That is why you check in the infra-umbilical point. Any other additional points, Shobna ma'am? You are not audible.
That is the reason I actually put my video on. I was listening before, but that this direction of flow is always confusing to students. So they have to understand that it has to be examined only below the umbilicus. Above the umbilicus, the flow will always be away from the umbilicus. It will
Okay,
always
that's
be
the rule.
from below
Check it.
upwards. Whether
Check
it is
it
portal
only
hypertension,
below the umbilicus. Yeah.
check only below the umbilicus because that is what differentiates IVC from other causes of portal hypertension.
Okay, so
Okay, ma'am.
the flow pattern, all that we will. Okay, now
What are
for
the cause? 1 minute, 1 minute. When do you get back veins in a cirrhotic patient?
Sir, madam, in IVC obstruction.
Flow obstruction.
Come on, yeah. What are the causes in a cirrhotic patient? Why should the IVC get blocked?
Madam, can be due to the Budd-Chiari syndrome.
Other than that, is there any less without any block or thrombus? Can there be an IVC block without any thrombus or partial IVC block?
Tense ascites possible.
Caudate lobe hypertrophy.
Okay.
Okay, I think there's a lot of scope for reading and improvement. I think you have to read up all these things.
1 minute, PT. So in a cirrhotic patient, if you get back pains, the causes are a cirrhotic nodule, large cirrhotic nodule, caudate lobe hypertrophy, tense ascites, and HCC.
Okay.
In a cirrhotic kindergarten case of cirrhosis, you have to look for back pains.
In fact, very often when there is tense ascites and once the ascites is capped or settled, some of those veins might actually become less prominent.
They
That is
disappear.
because of a functional IVC block because of tense ascites.
They disappear. Yeah. After
Yeah, they
tapping, they
disappear after
disappear.
the ascites is tapped. Yeah.
Okay, so this is just a read up sarcopenia and frailty, just to show all these things. Various studies are there which actually showed the role of sarcopenia, mild sarcopenia, mild. Somebody is making some noise. All this you have to start. And also, as the muscle mass reduces, first is muscle strength, muscle mass, muscle function, and various tests actually assesses various things. The hand grip and frailty assess generally muscle strength. Muscle mass can be found out by anthropometry, that is mid-arm circumference, bioimpedance, DEXA, CT lumbar region, MRI, ultrasound of the thigh, and various functions are gait, speed, 6-minute walk test, climbing stairs, standing from sitting posture, etc. So please prepare a short note or a short answer for frailty testing. So this will be useful for your examination also. Because nowadays examiners ask, once you find a malnourished patient in a cirrhotic, obviously the question will be coming. Definitely they will ask you sarcopenia, the test and test of frailty. Okay, it will be us. Anything else to add, Jayanti ma'am? This is the index which I told. There is an objective way of doing it. That's a calculation. There is an online calculator also. This, of course, you cannot do it in the exam hall, but you can answer that. It's possible. We can do all those things. Okay. So that's it, Sobin. So you have to read up. Okay. So try to read up all portions which we covered just now, so that it will be, and the various vascular indices also which we showed. This may come as a short note, or will be asked in the clinics or in the Viva, etc. Okay.
Okay, sir.
Okay, Sobin, thank you. The third person.
Thank you.
Sir,
Okay, Dino,
yes, sir.
you have to go through fast. You will only have 15 minutes.
A 38-year-old male admitted with the new onset jaundice. He has history of end-stage renal disease secondary to membranoproliferative glomerulonephritis. He has undergone a cadaveric renal transplant nearly 15 years ago. He is well until 2 weeks ago when he noticed upset stomach with nausea, non-bloody emesis, and loss of appetite. Dark colored urine for 1 week with fatigue, malaise, and he has lost few kilograms since the onset of his symptoms. He is on cyclosporin, mycophenolate, and prednisolone after renal transplant, and he has received blood transfusion during his renal transplant in 1991 and was maintained on hemodialysis for several years prior to transplant. On examination, a well-developed, well-nourished gentleman who is comfortable and in no distress. Temperature 37.4 degrees Celsius.
Okay, normal, BMI 25.9. Okay. Next.
Yes, scleral icterus, abdomen soft, flat, not tender, liver is not enlarged, spleen is not palpable, no appreciable ascites. Investigations wise, WBC count is 14,000 with glucose neutrophils of predominant neutrophils of 88%. Hemoglobin 10 grams, normal MCV is 75, that's lower side. Platelets normal 3,25,000. Creatinine is 5.5. Bilirubin, total bilirubin 8.3. Direct fraction of 5.7, AST is 270, ALT 330, alkaline phosphatase is 150, gamma GT is 220. Albumin is 3.2 and INR 1.5.
What do you think is having?
28.
What do you think he is having now? That's the current problem.
What are the comorbidities he has?
Chronic renal renal
One,
disease.
any other comorbidity, diabetes?
No,
Been mentioned.
Any comorbidity, VT?
no. No comorbidity. The fact is that he had a renal transplant. He is on a immunosuppressant for the last 15 years or so, and currently he has some degree of renal dysfunction also.
Yes, sir.
On immunosuppressants, some degree of renal dysfunction, and the current problem. So, do you know what you think is the current problem?
Sir, acute onset 2 weeks history of symptoms with the total bilirubin of 8. So most likely an acute liver injury doesn't fit into the diagnosis of acute liver failure. However, INR is mildly elevated, so 1.5.
What is strange about it if it is acute hepatitis?
Sir,
Is the liver function, liver biochemistry, does it totally support acute hepatitis?
no, sir. Enzyme
It
elevation.
is viral.
Yes, sir.
So AST LT is only moderately
chronic
elevated, which
Yes,
is
sir.
not the usual picture of a viral hepatitis. Okay, in
Chronic
viral hepatitis, you
hepatitis.
expect it to be much more high, thousands. Either you have taken after the initial phase, this is the LFT during the probably not in during the initial phase, or we may be dealing with something else. What are the possibilities? So if it is acute hepatitis, what do you think it is due to?
Sir, resolving acute viral hepatitis or drug-induced liver injuries.
Which drug is incriminated?
Sir,
Which are the drugs you think are responsible for the current problem?
in this patient, there is only
The
history
drugs
of
which you were on were
only cyclosporin.
cyclosporin, mycophenolate, and prednisone for immunosuppression.
Yes, sir.
So, are these drugs capable of producing DILI and acute hepatitis like picture?
Yes, sir. But he has been on long term. Whether there was any recent change in immunosuppression that.
There is no change.
Yes, sir. So he has been on long term immunosuppression. So these drugs are not likely to produce. But all causing a prednisolone could be a cause of cholestatic hepatitis, sir.
Prednisolone?
Steroids
Is it a common drug which will produce cholestasis? Which are the hormone which will produce cholestasis?
anabolic steroids and oral contraceptive pills. Sir.
Okay, see, this is how questions get directed, no? Is a prednisolone a common and incriminated drug for cholestasis? This is a drug which is used like anything. Every person is prescribing, no? GP is all people prescribe it left and right. So in which case we must be bombarded with so much cases of cholestatic jaundice due to prednisolone, corticosteroids. Are we seeing that?
Also.
So, and second thing, when you say an answer like this, remember the examiners get an impression that you probably have not read enough. Okay, this may be a mistake which you are casually committed, but be careful. Prednisolone is not a usual cause of cholestatic jaundice. Even I would say it's not even a rare cause of cholestatic jaundice. So what is the likely possibility? Acute, short history. What is the history like? So he had all these things, fatigue, malaise, all those things, upset stomach, nausea, etc. What are these known as?
Can you have a viral infection?
Prodromal.
These are prodromes, no?
Yes,
So
sir.
the classic prodrome. So he had a prodrome followed by jaundice. So it should be an acute hepatitis. And most likely it could be viral. So what are the viral diseases which are common in India which can produce a picture like this? We come to basic MBBS level. Is it hepatitis A?
And with changes in the kidney, no? Membranoproliferative.
Yeah.
MGN.
Is he having hepatitis A? Dinu. Is he having hepatitis E?
Just say yes or no.
Are you still connected, Dinu? Are you offline? If you are offline, Sumuk, can you answer?
Yes, sir. It can, viral hepatitis can be there, sir. Hepatitis A or hepatitis E, viral hepatitis.
He is,
But
what was the age of the patient?
Age of the patient is 34, sir. Hepatitis.
38. How often you get acute viral hepatitis in a 38-year-old person in India? And if there are any exception, you have to tell what is the exception.
Yeah, hepatitis A is unlikely, sir.
Hepatitis A and D are fecal-orally transmitted disease, and considering the overall hygienic status, what have prevalent all over our country. I am not denigrating our country, but unfortunately it is so. The fecal-oral infections are very highly prevalent in our country. So most people get during their childhood and adolescence. And it is extremely rare for an adult to develop hepatitis A at least. E, of course, maybe sometimes, especially females, but A is very unusual. So A
Yes.
usually happens if somebody has been sort of living in a situation where he was not exposed to ordinary all these things and suddenly goes to unhygienic situation. Okay, then it may happen, but otherwise it is unlikely. Okay.
Yes, sir.
Okay. So anything else other than A or E? So A or E is less likely. Can it be anything else? Can it be B or C?
Sir,
Does he
hepatitis
have a
B is
risk factor?
possible. Hepatitis B is possible, sir, because he might have membranous nephropathy, developed membranous nephropathy as an extraintestinal manifestation.
So yeah, membranous
Hepatic
nephropathy is a manifestation of chronic hepatitis B infection itself, no?
Yes, sir. So probably
Most
he's
probably they
having.
would have diagnosed it at the time of detection of renal disease also. Okay,
Yes.
is he vulnerable to any other viral disease?
Hepatitis.
CKD dialysis patient, are they vulnerable to any other viral illness?
Hepatitis C can, after dialysis, could
hepatitis
have
C.
developed acute hepatitis C.
Hepatitis C. I would say the highest risk is for hepatitis C, followed by hepatitis B. Okay. So,
Okay, sir.
and less likely for hepatitis A and E. And obviously, he has not changed any drug recently. So, probably it is extremely unlikely. And there is nothing much. Of course, in an immunocompromised patient, the patient has got severe hepatitis. One should also look for evidence of CME infection,
Yes, sir.
HSV
CMV.
infection, EBV, etc.
Yes,
So, those rare things should be looked if the patient has got severe ALF-like picture and you don't find any evidence of the ordinary infection by lab test. Okay.
Yes, sir.
So look at this.
Ultrasound, normal liver, no evidence of intra or extrahepatic ductal dilatation. HbS-Ag is positive. Anti-HbS is negative. Anti-HbC IgM is positive. HbE-Ag is negative. HbE-Ab is positive, and HbV DNA is.
Okay, stop at that level. There is an underline for HbEAg. You know what is that? Is it correct? Which is correct? HbEAg, this one is correct or the second one is correct?
HbEAg negative can be correct, sir. Patient is having.
Is there any typo error here?
No, sir. It looks like HbEAg negative chronic hepatitis.
No, actually, the first one is that's a typo. This is hemoglobin.
Oh.
HB is with capital letters. Okay.
Yes, sir.
I deliberately changed it this evening.
Yes, sir.
How sharp you people are. HB, this is like HbA1c, no? That is hemoglobin. HB short B. The other one is hepatitis B, specifically hepatitis B E antigen, hepatitis B E antibody. Okay. So it is usually written as H and B are capital letters. Okay, that's the standard way in which it is written. Okay, there should not be any doubt. I find many students writing hemoglobin like E antigen and E antibody. That's why they did it like this today. Okay, so okay, be careful. Use capital letters. Okay, HBV DNA is 1429 crores.
Yes, sir. It is more than HB DNA.
Okay, crores. 1429 crores means very high value. Okay.
9.
Yes, sir.
So what does this mean?
HbS-Ag positive, anti-HbC IgM positive, and HBV DNA negative.
Is it acute hepatitis
B?
B? Is it acute hepatitis B?
Yes, sir. Acute hepatitis B infection.
Why do you think so? What is the just now we were hovering in this area? What does it suggest?
Anti-HbC IgM is positive and HbS-Ag is positive.
HbAg is negative. If it is acute hepatitis B, do you expect HbE antibody to appear? E antibody to appear?
No, sir.
More of a reactivation, no?
So E antigen is negative. Usually
Yes,
in
sir.
acute hepatitis, E antigen is positive and E antibody is negative. Second, the DNA levels are not sky high like this. In acute
Yes.
hepatitis B, here it is extremely high value. So extremely high value, E antigen negative, E antibody positive. It has to be
Reactivation of hepatitis B.
chronic hepatitis B with possible
Chronic.
reactivation.
Yes,
This
sir.
is how you analyze. This is how you analyze.
You
Okay.
want to treat or you don't want to treat? Would you treat this patient?
Yes, yes, ma'am. This patient has extra intestinal manifestation. Extra hepatic manifestation. Patient is having HBV DNA more than 20,000. So, and is HBsAg positive. He has to be treated now.
Why
What are the
did you
chances?
say 20,000?
According to
For E antigen negative, what is the cutoff?
2000. 2000.
Ah, yes. For E antigen negative, it is 2000. Now, each of the word which you say no will be critically evaluated, analyzed. Okay, 2000, not 20,000.
2000. Yes, sir.
Okay.
What are the chances of him getting converted without treatment? He's
Ma'am,
acute, no? He's
if it
acute.
is acute, if it is an acute
He's acute.
hepatitis B, 95% chances spontaneously it will resolve,
In
ma'am.
this patient, in this patient, in this patient.
In
We're talking
that
about the
patient.
same patient.
Uh,
Would you treat this patient or you think that there's a possibility that he'll convert and become negative on his own? And if it is so, when would you reassess him? Because AST is not very high. Okay. It's just about 200 and something. No, it's not in thousands. So what are the chances of him just zero reverting and becoming negative in about what time? What will be the cutoff? When will you consider? Enzymes are not very high. So should I treat or not treat? I'm asking.
patient, he
Liver
has
is
to be
normal.
treated.
Liver is
Yes.
normal. There's no cirrhosis.
There is no cirrhosis, but there is jaundice. Transaminase is more than 3 times upper limit, definitely, no?
Yes, ma'am. He
And
more-
E
he
antibody,
has to be treated.
What are the guidelines now for treatment in a patient with reactivation? That's what we're asking. If there's a reactivation, what is the guideline?
For reactivation,
this particular patient, is there a strong indication for treatment? Yes or no?
it is there, sir. The extra hepatic manifestation is there, so he has to be treated.
Does he have any other risk factor?
No, sir.
No.
No, sir.
He's continued on immunosuppression.
Yes,
Okay,
sir.
ideally, you should have prevented this. How you should have prevented it? How could you prevent the occurrence of a reactivation of a hepatitis B?
When on immunosuppression, at least antiviral therapy should be given up to.
So before
6 months.
starting the
6 months.
immunosuppressive therapy, what all things you will check?
For antibody.
What is the usual thing first you will check? Because the scenario wise, a garden patient can have a hepatitis B positive also, no? Okay, so HBsAg. And if HBsAg is negative, according to different societies, there are different guidelines, but anti-HBC. Okay.
Yes, sir.
Very few societies say HBV DNA also, but generally HBsAg and HBC. Okay, these are the two things you check. HBsAg is positive. Obviously, that patient will be immediately assessed whether he is eligible for treatment otherwise. But if he is going to have an immunosuppressive therapy, you have to start treatment. Okay. If the patient is anti-HBC positive or DNA positive, you have to again give treatment. So how will you start treatment? How many weeks or months before starting immunosuppressive therapy you should give this?
At least for 6 months before.
No, the gap between antiviral therapy and immunosuppression.
I don't know, sir.
Because there are, again, societies do not agree on this, ideally 4 weeks, but at least concurrently. If there is an urgent need to start an immunosuppressive therapy and you cannot wait for 4 weeks, at least concurrently, but ideally 4 weeks. Okay.
Yes.
And how long you will continue?
6 months after stopping immunosuppressive therapy.
Okay, guidelines say 6 months, some societies again 12 months.
12
What
months.
drug you will use?
tenofovir alafenamide TAF is
Tough.
tenofovir alafenamide can be
Why
used.
are you against entecavir?
Sir, entecavir actually for entecavir dose adjustment has to be done, sir. Patients on hemodialysis.
And for tough,
TAF dose adjustment is not required, sir.
we are sure
Patient-
that the tough will not produce any renal dysfunction.
A TAF will not cause renal dysfunction, sir. No dose adjustment is required. If creatinine clearance more than 50 and patients on hemodialysis, tenofovir alafenamide can be continued.
Okay. Ma'am. Okay, and depending upon the type of drugs which we use, the immunosuppression and the possibility of reactivation, the ordinary drugs like azathioprine 6, mercaptopurine, and low-dose steroids and short-course steroids are considered as low risk. And in such situation, we do not do the prophylactic treatment. But all other situations where you have got a long-term high-dose corticosteroid therapy, biologicals, local therapy for HCC, B-cell depleting agent, especially rituximab and the rest of other drugs, and stem cell and solid organ transplantation. All these conditions are considered as high-risk immunosuppression, and always one should seek for evidence of current or past hepatitis B infection, and if there is a chance, you should treat it. Okay.
Yes, sir.
Anything, ma'am?
This
Any-
particular patient was HBsAg positive prior to transplant.
Actually, I have no idea.
Yeah, that's what. No, that's
And
why
I think
got
it was
confused.
he was not because they did not give any antiviral treatment before starting immunotherapy
But
or
we would
before
not
transplant.
know. We would not know because I think you mentioned membranoproliferative.
I think they did not check it. That would be the correct thing.
That's what he said. They may not have checked it. It's exactly.
Yeah. Because 15 years ago, probably that thinking was
Yeah, that's
not
what.
widely prevalent.
Yeah, they would not have checked it.
Yeah, they would not
That's
have
the
checked.
reason. And therefore, that's the reason why he could have had a reactivation.
Okay. So this is
You
a
want-
case of reactivation of hepatitis B while on an immunosuppressive therapy. And again, you should not have any doubts. You have to spell out fast. Okay.
Yes,
how you do it, all those things. Okay. And Dino, are you back? If Dino is not there, Sumuk will continue.
Yes, sir.
This is
Dino, do you want to take up this case?
Yes, sir.
Okay.
A 54-year-old man was diagnosed to have decompensated chronic liver disease, waiting for liver transplantation. He has been evaluated multiple times with history of cirrhosis secondary to hepatitis C and alcohol. His liver disease has been complicated by small varices, though no history of GI bleed. Past medical history unremarkable. Medications include diuretics and lactulose. He had shortness of breath. He has noticed decreased exercise tolerance over the last 1 year with the need to take rest during work.
Okay. What are the causes of dyspnea in a patient with cirrhosis decompensation?
Yes, sir. One is pulmonary causes. Sir. Pulmonary causes, it could be portal hypertension resulting in hepatopulmonary syndrome or a portopulmonary hypertension. Or it could be
Then alcoholic person, which is more likely.
aspiration.
Cardiac, no?
yes,
Cardiac myopathy, no?
causes.
Cirrhotic cardiomyopathy, alcoholic has got a more vulnerability. So whenever asked a question like that, it could be related to the cirrhosis and its etiology, or it could be totally unrelated. A person with cirrhosis has no immunity against developing any primary pulmonary disease. Okay. So you should have an open mind. So in the unrelated, okay, we are not much concerned about it, but related things, that's what we will be concentrating. So in the related to liver disease, what are the things? One is cardiomyopathy, I just said. You said portopulmonary hypertension, then hepatopulmonary syndrome.
Then hepatic hydrothorax and
Hepatic
mechanical.
hypothorax,
Most common
even
is
severe
mechanical.
ascites. Severe
Mechanical.
ascites.
Yeah, tense ascites.
Yeah,
Yes.
severe ascites. HCC can have METs. Then a person with a NAFLD, actually a person with a NAFLD, even though he has cirrhosis, cause of death may be due to cardiac problem, coronary artery disease. and they may be having left ventricular failure or congestive failure. So you should have an open mind about it. Okay. Don't jump to portopulmonary or hepatopulmonary syndrome. Okay.
Yes.
All these possibilities will have to be kept in mind. Okay.
Yes, sir. On
Physical?
examination, he is alert and oriented. Vital signs, blood pressure is normal, pulse rate 106, regular, and he is afebrile. Respiratory rate is 22 per minute at rest. He has significant palmar erythema and multiple spider nevi on the anterior and posterior upper trunk and mild pedal edema. Examination of cardiovascular system reveals normal heart sounds, chest clear, lung fields. He is more comfortable lying flat.
What is that known as?
Uh,
Actually, the cat is out. What is that?
orthodeoxia.
What is that known as?
Platypnea, sir. The orthodeoxia.
Platypnea. What is orthopnea?
Orthopnea is dyspnea in lying flat, sir.
Okay. And this is platypnea
Aggravated,
is dyspnea?
relieved on lying
Less
flat.
dyspnea
Less
when he
dyspnea
is
on
lying flat and more dyspnea when he sits up or stands. Okay. Okay.
He has a
Remaining findings, just palpable liver. There is dullness in the flanks. Okay. Lab.
Hemoglobin was 12.3 grams, platelet of 73,000, WBC 6,200, INR 1.3, creatinine 1.1, bilirubin 1.4, AST, LT are normal.
Okay. Albumin 2.6, chest X-ray normal. Ultrasound shows stronger liver with the dilated portal vein. No SOL, ascites plus. Okay. So, answer these questions.
Is the patient different from routine cases of cirrhosis?
Some audio disturbance is there.
He has features of cirrhosis with portal hypertension, sir. Apart from that, extra complication out of cirrhosis is you might have a hepatopulmonary syndrome because history suggests of platypnea, that is dyspnea aggravated in the lying flat
What are the
position.
usual clinical findings when you have a platypnea and a suspected hepatopulmonary syndrome?
One
What
is
are the other things you should look for?
saturation, sir, pulse oximetry, whether there
Clinical
is
examination,
clinical
cyanosis,
whether there is cyanosis, sir.
cyanosis, clubbing, and these are the patients who usually have extensive spiders also,
Yes, sir.
because probably the same mechanism works in the lung also to produce. Okay.
Sir.
Okay,
And,
exercise intolerance, you have already mentioned, we have already discussed. What are these intrapulmonary vascular dilatations? What are those?
Sir, actually, because of portal hypertension and release of nitric oxide, which in turn is activated by this nitric oxide, when it reaches the lung, will result in formation of this intrapulmonary vascular shunts.
Vascular shunts. Okay, so that is perhaps that is considered as the reason for this. So what actually happens? There is a what sort of a shunt?
Sir, from the that is deoxygenated blood will directly
So
get
right to left shunt, right to left shunt.
Yes.
So that's a right to left shunt happening in the lung. Okay,
Yes.
how is it evaluated? So what is exactly the reason for
Venous
platypnea?
shunt, no? AB shunt. Yeah.
What is the reason for platypnea? Is there any explanation given?
Platypnea is because in the supine position, the percentage of shunting of blood across this dilated vascular channels will reduce. So the patient
Actually, anatomically, more vascular shunts are in the lower part of the lung.
Basis.
so
For
that
some
is
reason,
compromised.
basal part. Okay, for some reason that we do not know why it is so. So during sitting or standing, more blood will be coming to the lower part, and it will be actually more deoxygenated. Okay, so it will not be oxygenated properly. How is the evaluation done? So how will you confirm whether there is this problem?
So one
The
is
hepatopulmonary
based on
syndrome.
oxygen saturation, sir. Based on pulse oximetry as well as room air arterial blood gas analysis, sir. Both in the sitting as well as in the supine position. And
So what is orthodeoxia?
orthodeoxia is a drop in the oxygen saturation in the supine positions. Sorry,
Hmm.
sitting position when compared to.
Compared to. Ideally, one should check it 15 minutes after changing the position. Okay. Second one.
Second one is arterial blood gas analysis to look for the arterial saturation. So usually,
Okay. To confirm the presence of this. Okay. Problem. Third.
third is if there is improvement in the saturation with 100% oxygen delivery. After supplementation of 100% oxygen, whether there is improvement in the
Okay.
oxygen partial pressure.
But that will not diagnose because most of the other conditions of lung
Diagnosis,
also
give a
you can
test.
expect the same. Okay.
Diagnosis to look for the shunts by bubble echo, sir, to look
So,
for left shunts.
okay. Ideally, a transesophageal echo with agitated saline.
Stated saline. to look.
Agitated saline. So, how does it differentiate between a left to right shunt occurring in the heart? This is a cardiologist perspective, but still I will ask. Suppose
Sir,
there is
usually
a
pulmonary shunts
ASD or VSD,
that will
and there is a right to
immediately.
left shunt. Pardon?
It will usually appear immediately after.
Yeah, within the first
stated
3
saline.
cycles. That is the usual thing.
This is
The
within
bubbles will appear on the which side? On the left side.
left side. Sir.
On the left side within 3 cycles if there is a intracardiac shunt, right to left shunt, or if it is happening in the lung, usually comes to the left side maybe after 4 to 5 cycles only. That is how they differentiate. Is there any other test scanning method?
Mass cancer, mass
Macro aggregated albumin. The mechanism is that macro aggregated albumin will have around 60 micron size and it will get trapped in the pulmonary capillaries, and generally it won't come to the systemic side. But in a case situation like this, it will reach the left side and then it will be concentrated in the brain, kidneys, liver, bone, etc. Normally this doesn't happen. Okay, so that is so.
Yes, sir.
And how will you treat?
Sir, based on the severity, sir, mild, moderate, and severe HPS. Mild hepatopulmonary syndrome, the definitive treatment is liver transplantation. Whereas other treatment options is long-term oxygen supplementation. If the patient is
Is there any medical therapy?
sir, vasodilators like percent and vasodilators.
So many drugs are tried, but I think none of these drugs are effective. Yeah, ambulatory oxygen, and if the situation warrants, I think liver transplantation. Is it a risk for liver transplantation?
Yes, sir. Severe hepatopulmonary syndrome, it actually reduces the post-surgical, post-transplant outcomes, the presence of hepatopulmonary syndrome.
So these dilated
Recovery will-
intrapulmonary shunts, will it become normal after transplantation or will it remain so?
It will.
Already this dilated vascular channels have developed in the lung, no? So is it a reversible thing or irreversible thing?
It is reversible.
Actually, it is reversible. It is reversible in most of the patients, but usually it takes about 1 year for the reversal to happen. So the improvement in the lung parameters will take about 1 year. Okay. Jayanti ma'am?
Yeah, most of the questions have been answered. No, I think that was fine. Yeah.
Yeah. I think that's so read about that. Some theoretical aspect of portopulmonary and hepatopulmonary syndrome, you must be thorough and you must be able to answer, and you should not confuse one with other. Okay, portopulmonary is like a portal hypertension, pulmonary hypertension. That's a trick. Okay, hepatopulmonary is the desaturation issue. So one must be clear about it. And the other one is portal hypertension and pulmonary hypertension. Okay, so that's a different manifestation altogether. Shobna ma'am, even though it's hepatology, I would like to get some of the comments.
For me today, it was a learning session. If it is hepatology, I'm only learning.
A student.
No, but it was good. And only one comment I had about the previous case, and that is more when I had spoken to my nephrologist, what they told me is that whenever the creatinine is high or the patient is on dialysis, the SGOT-PT tend to be underestimated.
Underestimated. If there is a CKD.
Careful. Yeah, in these patients with CKD, SGOT-PT tend to be underestimated.
Okay,
So
okay.
that is why that value of 200 also may
Yeah,
actually
that
be
could
an
be the
extra
reason
value.
why the value was low, even though he had probably acute hepatitis like reactivation. Okay, okay.
Absolutely.
That's a
Because
good
when
point,
you
ma'am.
have
So
iron load, we have
we'll just
expect-
take a question on that. When if the creatinine is normal, are you worried, Dinu?
Ma'am,
Are you worried when the creatinine is normal and still the patient could have an AKI?
yes, from the
What are the
baseline,
situations? What are the reasons? Why is creatinine a fallacious marker for kidney disease in a cirrhotic patient?
one is because of reduced muscle mass secondary to sarcopenia.
Good, yeah. Then
Second is the creatinine elevation can take a longer time, whereas kidney injury could have onset could have been prior to that.
the
Age.
other thing is creatine conversion to creatinine itself is defective.
effective in that.
Conversion of creatine to creatinine is also defective. So these are three reasons why creatinine can be fallacious in a patient with cirrhosis. Okay, that's why they have the other markers now. Okay.
Okay, today we discussed about encephalopathy also, but remember as a short note, you can have situation where the liver is not having cirrhosis or an acute liver failure, and you may have a patient with a hyperammonemia and encephalopathy like picture. Sumuk, is there any situation where the liver is normal, the ammonia is high, and the patient has encephalopathy like picture? Can you think of something in children, in adults? Okay, very rarely somebody with this patent ductus venosus can have it. Okay, that is one thing which we
Yes, I
discussed. Other than that, okay, to cut it short, urea cycle abnormalities. Okay, urea cycle abnormalities, they may have hyperammonemia syndromes, and in adults, it may be sort of partially expressed, and it may manifest only when they take some drugs which may affect their urea cycle. So the patient is hospitalized for some reason, then they take some drug which can act on the urea cycle, and then it lead to hyperammonemia and hepatic encephalopathy like picture, but liver otherwise may be normal. Okay, so try to read up that and also prepare some short note on that. Okay.
Yes.
I think
urea cycle. and
urea
defect,
cycle abnormalities, a short note on that. That can be expected always. Okay, and the treatment for that encephalopathy or rather hyperammonemia with encephalopathy is slightly different compared to hepatic encephalopathy. Okay, we use other agents like sodium benzoate, PABA, all those things also in those situations. I think we had a good session, and in fact, this is an eye-opener session for the faculty as well as for the students, because cirrhosis liver is very common in our ward, and I am sure if there is a case which has some important points, it will be kept in the examination. And any mistakes committed in the management, diagnosis, or approach to chronic liver disease, if you make, usually that mistake is not easily taken by the examiners. Okay, and in fact, some of the good students may have a bad outcome in the examination due to such simple mistakes. So please, I am not frightening you, but please read up cirrhosis. Please read all complications of cirrhosis, its management repeatedly, so that there is no doubt whatsoever. Okay. So wish you all the very best for your reading, and I request Dr. Jerry Abraham to say the vote of thanks.
Thank you, sir. On the
Thank
behalf
you,
of
Vicky,
on the behalf of President, I'd extend my sincere gratitude to Shobhana Bhatia ma'am, Jayanti ma'am, and Vagiswam sir for guiding us through the cases today. Also thank the residents who have volunteered for as discussants today. Also thank the IHC for organizing the clinics. Thank you.
Thank you.
Thank you.
Good night.
Thank you, sir.
Thank you, sir.
I am stopping sharing, and I am also Somna ma'am. Good night.
Good night.
Janti ma'am, good
Thanks,
night.
Vicky, for the nice four cases.
Do we
Excellent.
have a case on Thursday?
I don't know. I think that Thursday we're all traveling towards AIG, no?
Oh, AIG. Okay, therefore we will not be having any class.
We'll see next month onwards.
Okay, fine. Okay. Good
Thank
night.
Thank you. Bye-bye. Bye.
Bye.
Thank you.